Dr. Jorge Madrigal from Fino. He was the former president of the world last meeting in Cancun, Mexico. He's a neurologist. He was trained in USA in vestibular rehabilitation, and he's in private practice in Mexico City. Are you there?
Thank you very much. Yes, thank you very much. I'm going to present this in a different way. Just please stop sharing the screen. And I'm going to present these slides behind me with my webcam. So please, for all the attendants, just click in the right, left, in the upper right corner of your screen. Just put not the gallery viewing, but instead the speaker view. So I can be in full screen. That's because it's easier here to make this. Okay, well, let me put in this part of the screen. So I'm going to talk about vestibular rehabilitation. I have been always fascinated but how in the way this works for vestibular patients. And when we hear about vestibular rehabilitation, often in most parts of the world, we think about giving a sheet of exercises to our patients that mainly the pharmaceutical companies gave us to give to our patients. But by today's standards, it is not the best way to rehabilitate a patient. So in this lecture, I'm going to show you a very quick and objective way to see how we can improve the patient symptoms based not only in a recipe for everyone, but how to understand the problem with these patients and how to choose the right exercises for your patient. So seeing that way is very, very easy. But first of all, how did it start? How did the vestibular rehabilitation started? And this is interesting because that's the history of that exercises given in sheets. It started in the middle of the 1940s by Terence Cawthorn and Cooksey. They were working with patients that were treated for Meniere's disease with labyrinthectomies and also with head injuries from the war. And this was the first paper that addresses the vestibular rehabilitation. And those two doctors observed that the patients that has more movements, usually they went better and feel better. And an important thing in this first paper was I think that it's still very, very true. They say rehabilitation in vestibular injuries are not complete until the patients are returned to their normal work. And this is very important because as we saw in Leonel's lecture and in Nicola's lectures, we are not treating patients to only have a number, an objective number to go to the normal way. I mean, if we only see the patient with a vestibular injury for being a patient with a low gain in the V-hit, for example, we will miss a lot of patients that maybe objectively they have normal V-hit gain, but they are not happy patients. So this is very important. Our work is not finished until we can return the patient to the quality of life they had before the lesion. So those exercises that I think that everyone in the room has seen, the problem with these exercises are they are not focused on the problem, specifically the problem of our patient. I have seen patients with bilateral vestibular loss, unilateral vestibular loss, even central problems that are given the same kind of exercises. And for example, a very common exercise in this kind of lists, if you have a VOR problem, if you have problems with your vestibulocular reflex, there is no point to make an exercise to focus on a pen and to put the pen away and near. I mean, you are not working really the vestibulocular reflex. So it is better. I mean, if you don't have anything, this is better than nothing. But by today's standards, we have better ways to address this kind of things. So, as we saw with Nicola's lecture and with Leonel Luis' lecture, the main purpose of the vestibulocular reflex is to have foveation when our head is moving. That's because when we see an object or image, a complete image, we see very clearly in the part of the fovea. I mean, we have a very good visual acuity here. And as far as we stay away from the fovea, we start to lose a very important account of vestibular acuity. So what happens when we move our head? Well, the problem is that if I'm looking something and move my head, and if I only can see very well with the good visual acuity in the center of my fovea, I need to have a system to stabilize my image when I am moving. And that's the main problem of the vestibular injuries. This is a very nice example of how the birds can stabilize the image. The problem with the birds is that they cannot move the eyes very well. So they need to stabilize the entire head to have not a blurring image in front of them when they are moving. So in humans, we don't have this vestibular ocular reflex. We have a vestibulocular reflex that mainly serves for the same purpose. We can move our eyes to the opposite direction at the same time with the same speed and the same arc of movement to keep our image stable. And in this example, we can see how bad is our vision when an objective is moving out of our fovea. If you see this blue dot with the ABC letters, and of course in your screen is very clear, but if I move the dot a little bit, you can see that the ABC letters start to get a little bit blurry. Of course, here we're using the smooth pursuit. We're not using the vestibulocular reflex. But if we move the red balloon faster, you can see it's really hard to see the letters clearly. If I move this very quickly, it is almost impossible to follow the letters. And that's the main reason that our patient usually, when they don't have a good vestibulocular reflex, they try to get very steady, very stiff. And if you have a normal vestibulocular reflex and you see this ABC letter and you move your head with the right and the left, you will notice that you can move your head very, very, very quickly, and the ABC letter stays very, very focused. So we have this vestibulocular reflex. It's okay. All the morning we have talked about this. When we move our head to the left 40 degrees, for example, we move our eyes at the same time, the same degrees, but to the opposite side to have the eye position in space. That means the gaze without moving. That's the main thing with the VOR. When the VOR fails, we have this. We have this called oscillopsia, that it's our surroundings move when we move our head. Normally, we don't see this because when we are walking and our head is moving up, down, our eyes are moving in the opposite direction, so we do not see this. But for vestibular patients, this is very, very uncomfortable. We can measure this, and it's usually in vestibular rehabilitation very useful to measure this in a somewhat objective way. We have the dynamic visual acuity, that it's the comparison between the visual acuity in a static environment. For example, when you go to the ophthalmologist, They put a Snellen chart in front of you and take your visual acuity, but with your head still. So the dynamic visual acuity is compare that static visual acuity with the same visual acuity when you are moving. This is the Dr. Herman Kingma in Maastricht. This is another way to assess this. Usually the classical way to assess the dynamic visual acuity is to have a test moving the head to the sides. But this is very interesting because this mimics a more real life form, and usually it's a better way using speeds in a treadmill, so we can measure this. And in this slide, you can see how bad your visual acuity can be if you have retinal sleep. Retinal sleep, that means that the image slips in front of your retina, gets out of your fovea. And for example, if you have 20/20 in an Snellen scale of visual acuity, and when you move your head, your vestibular system is working well, so you don't have any movement in your fovea, you will have the same visual acuity when your head is still 20/20, and if you don't have any kind of retinal sleep, you will have 20/20 moving your head. If you have a vestibular deficit, for example, a deficit that moves the image only 3 degrees per second when your head is moving, your 20/20 of static visual acuity will worsen to 20/50, for example. And if you have a more severe vestibular injury, and when you move your head, you have a little as 11 degrees per second movement of the image in front of your fovea, your 20/20 visual acuity in a static environment will worsen to even 20/200. I mean, you are with a vestibular lesion of that size, you are legally blind when you are moving your head. So that explains that the last thing your patient wants is to move the head. And we use that for vestibular rehabilitation. The vestibular adaptation is very interesting because the retinal sleep, this error signal that drives the image out of the fovea, is the most powerful signal that can induce vestibular adaptation. Vestibular adaptation is the increase of the movement of the eye in comparison with the head. And this is a very nice example in David C's classical neurology of the eye movements book. If we have a monkey, a normal monkey that have a normal vestibulocular reflex, normal VOR, when we move the head of this monkey to the right, the vestibulocular reflex gets in, so they move the eyes to the opposite side while looking at a banana. So the eyes move in an opposite direction of the head at the same time, the same speed, the same amount of degrees. And because this guy is healthy, is not going to have any kind of slip in the retinal image. In this day 0, we put this monkey magnifying spectacles, magnifying glasses. He's normal. He's well calibrated, the eye in comparison with the head, but because the monkey has magnifying glasses, we artificially are making to feel oscillopsia while looking at the food. There's a sleep because the glasses. If we keep the glasses over the monkey's head for like 3 days, we're going to see this. We're going to see that the eye moves probably more than the double of the amount that originally was moving in order to stop the retinal sleep, in order to stop the oscillopsia. And this is interesting because our orbits, our eye muscles does not have any kind of position sensors that returns information to the central nervous system. So the only way that the brain can know that the VOR is working well is based on if we have oscillopsia or if we don't have oscillopsia. The brain doesn't want to have oscillopsia, and if if it notices that when you move your head, you're having this retinal slippage, it's going to use cerebellar ways to increase or decrease the vestibulocular reflex to avoid oscillopsia. And that's the main part of the vestibular rehabilitation exercises. We need to put our patients to see a little bit of controlled oscillopsia in order to use the cerebellar compensation systems to get better that patient. So it is a better idea to only use this kind of exercises. We use a post-it with a small letter right in the post-it, and the instructions are very simple. It's only put the post-it in your arm length, focus on the letter, and move your head as fast as you can, but you need to see the letter clearly. It is okay, and it's desirable to see the letter moving, because that's the signal that we need to use to increase the VOR gain and decrease the oscillopsia. Of course, our patients are not going to feel very well doing this, and we need to talk to the patients and say, well, that abnormal movement is the key to get you better. So if you're doing this exercise too slow and you're not feeling bad, maybe you are doing this in the wrong speed. So if you make this exercise and you feel like the letter is moving, so be sure that you're doing very well. It's like in the muscles, no pain, no gain. With these exercises is no dizzy, you're not going very well. So in this case, for example, this is a patient with a right vestibular loss, right vestibular hypofunction due to vestibular neuritis. And we can see easily in the clinical head impulse test that has a corrective saccade when we make the impulse test to the right. So he had a right vestibular loss. In terms of clinical evaluation, I put a letter in a paper in the wall, and the instruction was, okay, focus on the letter and move your head as fast as you can, but to keep the letter very, very clear. And this was the fastest he can move his head and do not lose the visual acuity in this letter. So when I took to the out of my office and say, okay, just walk and move your head at the same time. So he was very stiff, moved to the healthy side and to the injured side. So this is very clear that he's not detecting right the movements to the right. So we put, well, this is the VHIT. We clearly see that has a superior vestibular neuritis. The right anterior channel is with a gain of 0.39, and the horizontal canal is 0.29 of gain. And there's a lot of saccades, this covert and overt, scattered. In this time, we didn't have the PR calculation that Nicolas showed us in the previous lecture, but they are very scattered. There are saccades in a very broad amount of time. They are not gathered still. And we put the patient 2 weeks in only VOR exercises with the one with the post-it to the instruction is just focus the letter and move your head to the right and to the left as fast as you can, but to keep the letter in focus. And 2 weeks after, he can move the head very, very fast. I mean, clinically, we can see that something got better. And 2 weeks after, he can walk, moving the head to the right and to the left without any kind of deviations of the gait. And what happened with the V-hit? Well, in the V-hit, of course, he had an increase of gain of 0.63 in the horizontal canal and 0.71 in the anterior canal. Look how the saccades are now gathered. If we can measure a PR, we will see a better PR score. Of course, the result of the increase of the gain plus the gathering of these saccades diminished the amount of oscillopsion, and of course, subjectively, he's getting better. Now, this is the comparison between the two V-hits. See how all the saccades are now gathered, and the gain increases from 0.29 to 0.63. So it's very easy to see. And well, I'm not going to stop here. Nicolas told us about how they discovered that a patient with a gathered saccades, with a gathered responses of compensation saccades, usually it's a patient that's going to be happy, is going to be less symptomatic in comparison with a patient with have still scattered responses in the V-hit, no? And this is a very interesting paper of Adolfo Bronstein team that shows us that thing that I told you at the beginning of the lecture, that it's not always a direct correlation between how a patient improves the objective measures that we have in terms of how he feels. For example, they took 20 patients with vestibular neuritis, and they measured the subjective scales, the dizziness handicap inventory and the vertigo symptoms scale, in comparison with how well or how not well the calorics and the V-hit gain increases. And look at this. This patient 4 is a representative example. This individual was asymptomatic with a dizziness handicap inventory of 0, but had an ipsilational posterior canal gain of 0.33. That means this patient was with no symptoms, but he had a 0.33 gain in the posterior canal. In contrast, patient 20, who was the most symptomatic individual with a dizziness handicap inventory of 70, had normal V-hit gains for each of the canals above. That's important because I prefer a patient that maybe in the V-hit is not having a complete normal gains. It is more difficult to treat a patient with normal gains, but is still very, very symptomatic, no? And in the Cochrane collaboration review, Vestibular Rehabilitation in the last review, they concluded that there's a moderate to strong evidence that vestibular rehabilitation, that's movement exercise based, is a safe and effective approach for unilateral peripheral vestibular disorders. So I kept this lecture very, very simple, very to the point. We are ending, I think, in time, because it's easier to understand what's wrong with the patient and to choose the right exercise to get this patient to get better. So thank you very much for your attention. And if you have any questions.
Thank you,
Jorge. Sorry, go ahead. Sorry, someone else was saying.
Thank you very much for the excellent and very techno presentation. And here you had a question in Spanish. Can you translate it for us and answer it?
Let me see. Have you designed any strategy for the fast evaluation so you can give a treatment of vestibular rehabilitation initially? What it consists? Okay. I don't think we have a very fast evaluation. I mean, every patient is different. And of course, for example, if you have speaking of vestibular neuritis, you can have an upper nerve vestibular neuritis or a inferior nerve or a complete lesion, vestibular lesion. So it is, I mean, you can give movements and you can be as non-specific and saying, okay, if that movement bothered you, so repeat and repeat and repeat that movement, because usually that kind of movements shows you a deficit in the vestibulocular reflex. So maybe this is as fast as you can go, but I recommend you to analyze if all the ocular motor movements and the vestibular ocular reflex movements are working. If you can measure, it's better. And try to choose the correct exercises that approaches that failure specifically. I don't recommend, I mean, for a patient, you will need to give a lot of repetitions. I mean, usually we give the patients to exercises 5 times a day. So it is not very good to make the patient to make 15 different exercises, to choose maybe 4 only, but very focused exercises on that deficit.
Very nice talk. What do you advise patients later on to hold a ball and throw the ball up and down and catch it while walking, and trying to do gait and look to the side? When you showed that video was very nice when he turns his head to the side. So maybe juggling a ball while he's walking and things, or does that come later in the stage of rehab?
Yeah, I have patients that, well, this kind of lectures is interesting because this lecture, these slides, I show to the patients and say, okay, this is the main objective. And we're working together on this. And I have a lot of patients that say to me, okay, you leave me the exercises for 5 times a day. But when I am driving, I look to the other cars' letters in the plates, and in the red lights, in the traffic red lights, I start to move my head to the right and to the left and right to the left. So it's interesting. And of course, if the patient understands what is going wrong with the vestibulocular reflex and understand really what's happening, you can have a better patient because he's understanding. And of course, maybe he will do the exercises better and more often than if it's only a recipe that follow this sheet of exercises and let's see you in the next month, for example.
So you are targeting mainly the vestibulo-ocular reflex, not the vestibulo-spinal, not the vestibulo-colic. Your exercises are mainly towards the vestibulo-ocular reflex?
Well, when you move your head, you're combining the vestibulocular reflex and also with the vestibular spinal reflexes. Usually in vestibular neuritis, for example, even in the 3rd or 4th day, usually the vestibular spinal reflex are getting well. I mean, it's not common to have a patient after 5 days of acute onset of vestibular neuritis that can make a Romberg, even a Romberg on foam in a very good condition. Usually, at least in the patient that I have seen, the main complaint is the oscillopsia, the movement of the environment when they move the head.
Jorge, that was a great talk.
Thank you.
I have a question. Do you use the near reflex targets at near, since the VOR gain increases with divergence? Do you particularly use near targets?
Yes, I use both. I put the patient on exercises 2 or 3 meters away with just a bigger letter, and also with a target of the distance of the arm. It's very noticeable that when you put a patient to make the VOR exercises, they can do it faster when they have the objective closer than in comparison when they have a farthest objective. In fact, I put the patients to walk once in a day, 20 minutes of walk, but in the outside. Because if the patient stays inside of the house, the farthest things to focus, they are, I mean, maybe 4 meters. And if they can walk in the street, they will have objects in 50 meters, 100 meters, and it is a more difficult challenge to keep the image stabilization in far objects. So I put different distances.
What about rehabilitation for patients who have residual symptoms after BPPV, when you have repositioned it and there is no longer any nystagmus, but they still feel dizzy? Maybe they have triple PD following a little bit. It's I mean, you don't really call it triple PD because it's not 3 months, but they have little residual symptoms after an attack of BPPV. So how do you tackle that rehab in that?
Well, the BPPV with residual dizziness, it's a very challenging patient, because I have seen, for example, that a lot of patients, especially the ones who got very scared with a big, fast nystagmus and very hard BPPV, they can develop, for example, a 3PD after the BPPV. So there are like a phobic thing about move the head or lay down on the bed. I use for this, this residual dizziness the Brandarov's exercises. Is not really exercises for the VOR, because rarely they complain about that. I use Brandarov exercises, thinking about if I can maybe dissolve the very small of otocoinia that can be left in the canal after the repositioning maneuver, or more or less to get the patient to face the fear to get laid to one side or another. I use that.
There are a couple of questions. One is from Zuma. I would like to know about your experience about head impulse in vestibular rehab in vestibular neuritis. Great presentation.
Oh, thank you. Francisco, I think I don't understand very well. What's my experience of...
Active. He's asking you about active head impulse, not passive, what you are doing, but patient himself doing it. I think that is what he means.
Yeah.
I mean, I'm moving the head of the patient?
Normally,
or...
that is passive head impulse, what we do to the patient's head. But active is you ask the patient to move his head fast to either side. It's like a VOR, but do it jerkily and fast.
Oh, like in, for example, like auto head impulse, for example, if I understand well. Well, I not usually work in these fast movements of the head because I think that a more physiological approach. I mean, in the normal life, you're not going to move the head like this fast in their normal life. I try to put the patient in a continuous challenge. I put myself in front of the post-it and said, okay, thinking that I'm normal, this is the speed you need to move the head and still focus right the letters, no? So you need to reach this speed. If you can reach this speed without feeling really weird, and you can also look at the letter and keep focus on this, if you can do this, you are going to be pretty normal. I have no experience with the fast movements as a rehabilitation therapy.
There's one more question. Do you recommend movements of the head only in the horizontal plane or in the vertical also, or combined?
No, in the horizontal and in the vertical. I mean, we have more movements. We can make an oblique movement, but usually the most, well, when you walk, the most useful movement is to try this, because when you're walking, your head is like this, and you need to have this a vertical vestibulocular reflex working well, so you don't have oscillopsia when you're walking. And this changes, for example, if you have a complete unilateral vestibular loss, maybe you're going to have the same amount of deficit in the horizontal plane in comparison with the vertical plane. Usually in a vestibular neuritis of the superior nerve, you will have damage 50% of your detection system in the horizontal plane. So the patient are going to feel it worse when they move the head horizontal. But if you only have damage the anterior canal, you only have damage in the 25% of the 4 vertical canals. So usually the vertical oscillopsia is not as bad as the horizontal oscillopsia, but it's recommended to give exercises for horizontal and for vertical movements. And if there is still another movement that maybe in your particular patient that says, for example, I move my head a lot in diagonally, and I feel dizzy when I do this. Okay, after the complete rehabilitation, I put the patient to try to find if there is a movement that can get dizzy that we were not working before, and repeat that movement again and again and again, because in that particular patient, that movement could be important for the normal life.
I think we'll take one last question. Is there any clinical evidence of vestibular rehab in vestibular migraine?
Well, in vestibular migraine, the problem is that you don't have a deficit of the vestibulocular reflex. I have only talked about a deficit in vestibulocular reflex. You can use vestibular rehabilitation, for example, for habituation. Usually the vestibular migraine patients are very sensitive for certain kind of movements. There's a scale. It's a motion sensitivity quotient that it's used to measure how our patient is sensitive in different kinds of movements. You can use this scale to see which movements are mainly asymptomatics, which movements are very, very symptomatic, and choose the middle ones and try to put your vestibular rehabilitation program in this patient. But the aiming is different. You're working with these patients more in terms of habituation more than central compensation, because you don't have in that patient a lesion in the vestibulocular reflex.
Very good. Thank you very much, Jorge.